going to talk about the TRACK Mpox study, which is a multidimensional epidemiology and community response to Mpox in Bujala in the Democratic Republic of the Congo. So as I'm sure many of you are all aware, Mpox is a viral zoonotic disease which has a very high burden in the DRC. There are two subclades currently circulating in the country, clade 1A, which is endemic in many central and western provinces, and new clade 1B, which emerged in September 2023 and has since caused widespread outbreaks in the east of the country in many previously unaffected regions. So while Mpox is certainly not new to the country, there has been a year-on-year increase in the number of reported cases in recent years, from approximately 14,000 suspected cases in 2023 to more than 40,000 suspected cases in 2024. In Doumbia province, which is in the north-west of the country where clade 1A is endemic, is among the top 5 most affected provinces in the country. So in June 2024, MSF Western Central Africa launched an emergency response in Bujala Health Zone, which was the epicenter of the outbreak in Doumbia province, and support there included case management, epidemiological surveillance, and operational research. So the motivation for carrying out research in this setting is that, especially compared to clade 1B in the east of the country, there are fewer recent studies on clade 1A in endemic settings. So a real need to understand both the true burden of Mpox in these endemic regions, but also perhaps what is driving transmission and the increase in number of cases. So the overall aim of the TRACK Mpox study was to describe the epidemiology of Mpox clade 1A in Doumbia, with specific objectives including describing the demographic, epidemiological, and clinical characteristics of cases, identifying risk factors for disease and severe illness, and estimating the attack rate among the general population. So there are a number of activities that we carried out in order to answer some of these questions, which we're just going to focus on 2 of them today. So the first activity was cross-sectional survey of cases, where we conducted interviews with Mpox cases identified in Bujala Centre Health area between January and December 2024. And the second activity was a multidimensional household survey in Bujala Health Zone, asking questions about Mpox incidence, mortality, vaccination between January 2024 and the interview date in April 2025. So I'll now present some results from these 2 activities. So first, some results about the interviews with cases in Bujala Centre Health area. So 527 people were interviewed during this part, of which approximately half were female and 65% less than 15 years old. The characteristic rash and lesions characteristic of Mpox were reported by all cases and were most commonly reported on the face, torso, arms, and legs. The extent of the rash varied, ranging from localized to just a small area of the body, such as arms only or legs only, to widespread rash. And 16% of cases reported this widespread rash, which we defined as affecting 5 or more areas of the body out of 7 total. Through univariate logistic regression, we found that although there was no difference in the likelihood of reporting widespread rash according to sex or age, it was most commonly reported among some specific symptoms, namely swollen lymph nodes, sore throat, difficulty swallowing, loss of appetite, and fatigue. In terms of severity, 17% of cases were hospitalized with a median length of stay of 8 days, and this was significantly more likely among people who reported these widespread lesions. 4 individuals reported long-term ocular complications, although no deaths were reported among this particular population. Finally, in terms of transmission, 42 cases, or 8%, reported at least 1 or more additional cases in their household, and children less than 5 years were much more likely than adults to report illness when in a household with another Mpox case.
I will now present the data from our household survey. We surveyed a total of 1,438 households, reaching all the 17 health area of Bunjala health zone, with a very few refusal rate. Most of the households were large, averaging about 6 people per household. The most occupation reported during this survey was farming. From an epidemiological standpoint, we have an overall attack rate of 2.0% in the household, in the health zone, and with a high transmission in the northern part of the health zone. Household size played a role in the transmission. Among all of the Mpox cases we found during this interview, nearly 80% of them live in the household with a size above 5 individuals per household. So we also found that children under 15 years old represent 2/3 of all the Mpox cases found in the survey. Also, we noticed that there was a vaccination campaign which was organized by the Minister of Health to control Mpox disease. So this vaccination include MVA-BN vaccine and targeted individuals above 18 years old, and also the high-risk population, including healthcare workers, the contact of cases. So we found that the coverage of this vaccination was only 17% in all the health zone. So from January 2024 to the interview dates, as a recall period, we found a crude mortality rate of 2.1 per 10,000 per day per person. So also we try to investigate about the number of cases. So we found that only 4 deaths in this study among Mpox cases, which is corresponding to 2.1% of case fatality rate. While analyzing for the risk factor closely, we found that the strong predictor of Mpox in this population was having another Mpox in the household. This represent this population have a 7 times order ratio, increase order of order ratio compared to those who don't have any Mpox case in their household. So also age matter. Individual above 15 years old had and half likelihood to get Mpox compared to children under 15 years old. So also we found that the crowding of households also was associated with Mpox, specifically people living in a household with the size above 5 have 70% increase order of Mpox compared to those living in smaller household. So here, after adjusting in the multivariable model, we did not find any association between Mpox and sex, occupation, and the density of area. So to conclude these two pillars of our study, so we could say that the burden of Mpox in this health zone was higher, and then we found also that many of people sought care, which is a strong indicator for community responsiveness and also for care-seeking behavior. This is a good indicator which you'll find. Only 17% of individuals who went to hospital got hospitalized during this survey. And then we realized also that the main risk factor for Mpox are age and the size of household. So which are the main driver of Mpox transmission in this community. So we would like to thank all our collaborator partners from MSF Waka, from Epicent and University of Kinshasa, and the Minister of Health with the DPS, Division Provinciale de la Santé de Sud-Ubangi. Thank you all for your attention.